Good afternoon, everyone. Thanks for joining us. We're going to give it a couple of minutes to fill the room here. Good afternoon once again, everyone. Thank you for joining us. We're going to give it about another minute to fill the room. Good afternoon, everyone. We'll give about 30 more seconds to fill the room here. Wonderful. Well, good afternoon, everyone. Thank you once again for joining us for our weekly Wednesday webinar series. Today's webinar is on COVID-19 vaccine implementation. My name is Brett Spitali. I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, July 16th. I'm joined today by Dr. Karen Remley, who is the director at the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. Thank you for taking the time to join us today, Karen, and I'll now turn it over to you to get us started.
Great. Thank you very much. And thank you for the opportunity to share information about the COVID vaccine. And for some of you who are wondering why the director of the National Center on Birth Defects and Developmental Disabilities is speaking with you today, the Division of Blood Disorders, and in particular, thalassemia, hemophilia, sickle cell disease, and clotting disorders are also in our center. We'd love to have the federal government change our name so that it would incorporate blood disorders, but that's why I'm here, and thank you for inviting me. What a great partnership we have had with the National Hemophilia Foundation and so many of you through the years. And I appreciate the opportunity to talk with you and how we could be curious and learn together about these vaccines. In full disclosure, I need to let you know I have been vaccinated, as has my entire family, including my adult daughters, husband, and son-in-law. We cannot wait until our toddler grandson can also be vaccinated. Right now, we surround him with a cocoon of love by making sure that each one of us who are around him are vaccinated. I'm going to share today data about the status of the pandemic, background on the vaccines, research that's being done, and where we are headed. So let's go ahead and get started and go to the next slide. I wanted to share with you, this is literally a screenshot from yesterday from the CDC COVID data tracker, because I think we've all been hearing about COVID-19 for so long now, it's hard to put it all into perspective. But if you can look, cases in the last 30 days have started to climb up again. We're at over 33 million cases. Total number of deaths are at 604,000. And if we look at 67.7% of adults in our country have received at least one vaccination. And then also important in this snapshot, we are still at moderate community transmission as a country writ large. Next slide, please. And we always look at our daily cases. This is one of those things when I wake up in the morning, I go to see where we're at. As you can see, things look much better than they did either early on in the pandemic or during our peak last winter. But as you can see, there's a worrisome, it's starting to be an increase in cases. We've had a 16% increase last week to this week with 15,000 cases per week being reported. And as you've heard in the news, and you can see when you look at our data, there are hot spots around the country where vaccination rates are low and cases are spreading rapidly. Next slide, please. And we know that cases don't tell the whole story. We also need to look at hospitalizations of patients. And again, what you can see reflected here is in the winter, significant numbers of hospitalizations. But what is worrisome is here in July, we're starting to see the numbers creep up again. So again, concerns about the fact that more people are being hospitalized again as case rates go up. Next slide, please. And then lastly, what we never want to see are those trends in COVID deaths reported to the CDC. And so currently death numbers around if you look at the country red whole, are continuing to slowly come down. But again, there are parts of the country where death rates have stabilized or are starting to go back up again. Next slide, please. And then lastly, I wanted to talk about emerging variant virus cases as we talk about what COVID looks like in our country right now. Viruses constantly change through mutation, and new variants of a virus are expected to occur over time. Sometimes they emerge and disappear, other times they emerge and persist. Multiple variants of the virus that causes COVID-19 have been documented in the United States and globally during this pandemic. The CDC has systems in place to monitor how common these variants are and look out for the emergence of additional new variants. And so if you look here, this slide shows you variants of concern, and you can see they're named two different ways. Originally, we named them by the B117 and then switched through the World Health Organization guidance to Alpha, Delta, Gamma, Iota as the names. And the Delta variant is the one that is actually now expanding around the country and is thought to be more contagious. So if you look, we can see that we're monitoring those, and you can see based on the colors, the orange, what parts of the country we have more of the Delta variant. And we continue to monitor this very closely. They seem to spread more easily and quickly than other variants, which may lead to more cases of COVID-19. And an increase in the number of cases will obviously put more strain on healthcare resources, lead to more hospitalizations, and potentially more deaths. And we'll talk more about this later, but so far studies that suggest that the current authorized vaccines work on the circulating variants, and we are continuing to study these and other variants. Next slide, please. So let's talk about the vaccines now. We kind of talked about where are we at with COVID. It is still with us, and it still has the potential with all of the people who are not vaccinated to have a significant impact on their health and well-being, but also on our entire country. There are currently authorized 3 vaccines that have received emergency use authorization from the FDA in the United States, and they're listed here. We'll talk about the differences. The Pfizer-BioNTech vaccine is authorized currently for persons age 12 and older, while the Moderna and the Johnson & Johnson vaccine are authorized for people 18 years and older. All 3 vaccines were tested in diverse adult populations, including minority groups and older adults. All of the available vaccines had been proven effective in preventing serious illness, hospitalization, and death. And we have research that continues to demonstrate that mRNA COVID-19 vaccines offer similar protection in real world conditions. And I will show you later, over 159 million doses have been given. So those initial studies that were done before these vaccines had the emergency use authorization now have a lot of information from the real world. We do not know yet how long the protection from receiving a COVID-19 vaccine might last, but are doing studies to monitor that. Next slide, please. So I wanted to share with you, because this is fascinating and new technology. And I say new, meaning it's about 10 years old that people have been working on messenger RNA vaccines. So how do they work? In order to trigger an immune response, many vaccines think of putting a weakened or an inactivated germ into our body. So that's the traditional type of vaccines that we as pediatricians are used to, and that many of us have gotten in our childhood and in adulthood. But mRNA vaccines are different. Instead, they actually teach our cells how to make a harmless piece of what is called the spike protein. So they're teaching that mRNA is using your own body to make that spike protein. The spike protein is found on the surface of the virus that causes COVID-19. This protein piece serves as an antigen to trigger an immune response inside our bodies. So our body recognizes it as being foreign and fights that. And the way to do that is by developing antibodies. And so that immune response produces our own antibodies against that antigen, and then that protects us from getting infected if the virus enters our bodies. Genetic material from the vaccine is destroyed by our own cells. once copies of the spike protein are made and it is no longer needed. So it's a very elegant solution in that it uses our own bodies to develop that immune response. Next slide, please. And then the Johnson & Johnson vaccine is different. It is a viral vector vaccine, and they use a modified version of a different virus. So that's the vector to deliver important instructions to our cells. So for COVID-19 viral vector vaccines, the vector, which is not the virus that causes COVID-19, but a different harmless virus, enters a cell in our body and then uses the cell's machinery to produce a harmless piece of the virus that causes COVID-19. So imagine just a little piece of that virus. This piece is known as that spike protein again. And again, it's found on the surface of the virus that causes COVID-19. Then we again make that antibody in our body to that spike protein, which provides immunity. The important thing is this is not a live virus vaccine, so the virus cannot multiply or replicate inside of your body. Next slide, please. So we just did, complex microbiology. Now we'll move on to vaccine effectiveness. What have we learned so far? The vaccines are effective in preventing COVID-19 severe disease and deaths. What we're still learning is how well the vaccines protect people with weakened immune systems, including people who take medicines that suppress the immune system, how long those vaccines may work, and how many people have to be vaccinated before the community can be considered protected, and how effective they will be against emerging variants. So as you can see, here's the data on the slide that demonstrates what we learned from the clinical trials, but also reinforce what we're seeing in the real world setting as we give millions of vaccines. Next slide, please. And many people are concerned because they heard this was a new vaccine and want to understand, how do we monitor vaccines? And so we're going to spend some time walking through this to make sure people have a real understanding. So as you can see on the safety monitoring timeline, there is a lot of work that is done previous to this dot that is in the development to the vaccine and the trials that are done. As you know, the trials were done by both the companies and the NIH to develop the vaccines. Once the vaccine is released or vaccination starts, we have multiple systems that look at vaccine safety. So it's a comprehensive and multi-pronged approach that takes into consideration multiple different reporting mechanisms so we can respond very quickly to any developments related to vaccines. So the CDC and the Department of Defense initially put in place robust systems to monitor vaccine safety. These systems enable both active and passive surveillance. So means we're actively watching for any issues that may occur, and passive means people may be reporting to us if they identify that, and tracking of COVID cases over time. The vaccine safety monitoring plan uses existing established systems as well as some new systems to monitor COVID-19 vaccine safety. And I can say, as a pediatrician and someone who's been involved in vaccination for my entire career, this is the most watched, most informed comprehensive vaccine safety monitoring program that we've ever had. So Be Safe, that you see at the top, is active surveillance. It's a new system. It's smartphone based, and many of you have been vaccinated, may have been asked if you wanted to enroll in Be Safe. They use text messaging and web surveys to provide personalized health check-ins after you receive that COVID-19 vaccine. So you enroll and you get messages to you to ask you how you're doing, and various questions about your health and well-being. VAERS is a passive system, which is an early warning system that detects possible safety issues with US vaccines by collecting information about adverse events. So any possible side effects or health problems that occur. And an important thing about VAERS is that system has been in existence for many years, and most physicians who, especially physicians who vaccinate on a regular basis, are used to using this system and have a very low threshold to reporting anything that they think might possibly be related to a vaccine. And then a key element of building trust in these vaccines is to make sure that all of us understand how comprehensive these vaccine safety systems are, as well as providing transparent and early safety data and monitoring results when available. So I think one of the things that shows how that system worked is the J&J rare adverse event reporting demonstrated how quickly we were able to look at data and say that this is an incredibly rare event, but one that we were able to pick up. Next slide, please. So we talked about VAERS. It was established in 1990, and it's a national vaccine safety surveillance program. It is co-managed by the CDC and FDA, which is important because it looks at all of the various components. It is an early warning system, as I said, and it collects information about adverse events. VAERS accepts and analyzes reports after a person has received a vaccine. Importantly, anyone can report an adverse event to VAERS. So healthcare professionals are required to report certain adverse events, and vaccine manufacturers are required to report all adverse events, but patients, anyone else can also independently report what they think may have been an adverse event after vaccination. It relies on all of us to put this in. It is not designed to determine if a vaccine caused a health problem, but it is there to be that safety signal and to detect any unusual or unexpected patterns that might indicate a possible safety problem. And then we look into the issue more deeply. Next slide, please. So we talked about vSafe using text messaging and web surveys. They can report any side effects or health problems. This has been a particularly helpful way for us to identify how many people who've been vaccinated, for example, are pregnant. Because women will self-declare as they fill in those text messages. And we encourage everybody to participate in the text messaging, vSafe, because it also allows you to get a remembrance of when you need to get your second vaccine. Next slide, please. And I know this may seem redundant, but I think it's really important for all of us to understand the multiple layers of vaccine safety and adverse event monitoring that go on in our country. VSD is the Vaccine Safety Data Link, and these are sites that work. It's a collaborative project between our Immunization Safety Office and 9 different healthcare organizations around the country. Again, it started in 1990 and continues to monitor safety of vaccines and to conduct studies about rare and serious side effects and adverse events following immunization. The electronic health records from each participating site, including information about vaccines and information on medical illnesses that have been diagnosed at doctors' offices, urgent care visits, emergency department visits, and hospital stays are included. And they conduct vaccine safety studies based on questions or concerns from the medical literature and report those. So they're very actively involved in looking at specific patient populations to identify impact of COVID vaccine. Next slide, please. So, and we talk about, I described, these are the different types of information in that program. And I think what's important here to see is it's very extensive. So everything from birth and death certificates, demographics, any kind of medical information you can see. Next slide, please. And then lastly, there's the CDC Immunization Safety Assessment Project, where there are 7 participating groups. This was established to, again, make sure that we did vaccine safety clinical research. And these are experts from those medical centers and other partners, which provide a comprehensive vaccine safety public health service. There's high quality clinical research being done, complex clinical adverse events following vaccination, and facilitates our collaboration with vaccine safety experts at leading academic medical centers and national capacity for vaccine safety monitoring. So in addition, they provide consultation to US clinicians who have questions about vaccine safety or specific patients. So next slide, please. I hope you heard through all of that there really are multiple redundant and overlapping systems to really look at the impact of vaccination in terms of side effects and any possible adverse effects that are being monitored every day as we speak for not just COVID-19 vaccine, but any vaccines that are received. So now let's talk about if you get that vaccine. What are possible side effects after getting the COVID vaccine? What's very common is on the arm where you've gotten the shot to have a little bit of pain, redness or swelling. You may feel a little bit of tiredness or headache, muscle pain, low-grade chills or fever, and nausea. And what can you do? Clearly, to reduce the pain and discomfort where you got the shot, a clean, cool, wet washcloth, and using your arm to just kind of loosen up that vaccination site, drinking plenty of fluids and dressing lightly. I think what's important here at the bottom of the slide is it's not recommended that you take the over-the-counter medicine before vaccination, but it's perfectly appropriate to take it after vaccination if you have a fever and need to have additional uh, therapy to lower your fever. These symptoms are really a way that your body is telling you that it is developing those antibodies that we talked about to the spike protein. So are mild side effects that are very consistent with what we would expect to see happen. Next slide, please. So a lot of questions have occurred around people with underlying medical conditions and thinking about what do we know and what don't we know. So we're looking at, there are multiple clinical trials that are going on. mRNA vaccines may be administered to people with underlying medical conditions with no contraindications. Clinical trials demonstrated similar safety and efficacy profiles in persons with certain underlying medical conditions, including those that place them at increased risk for severe COVID-19 compared to people without comorbidities. And we know that people with HIV infection, other immunocompromising conditions, or who take immunosuppressive medications might be at increased risk for severe COVID. You may not be protected if you're fully vaccinated. Data suggests that the immune response may be reduced in some immunocompromised people. And so at this time, many of you have heard that data is coming out of Israel. We at the CDC, in partnership with the FDA and NIH, are looking at that data and the data that we're collecting to identify if there are certain immunocompromised conditions where there may not be adequate immune response after vaccination. But we recommend that all individuals talk with their provider, and if there's any concern, to continue to socially distance and mask as we learn more about the efficacy of the vaccine in immunocompromised people and the longevity of the vaccine impact. Next slide. So there are very rare but very real contraindications. These are people who should not get a COVID vaccination. And that's someone who's already had a severe allergic reaction to a previous dose or to a component of the vaccine, or has a known diagnosed allergy to a component of the vaccine. And people with a contraindication should not receive either of the mRNA devices. So the one that is the most common to be discussed, which is a very rare allergy, I say common because it's the most common item in the vaccine, is the PEG. And if you have a cross-reactive hypersensitivity with the vaccine, it's incredibly rare, and you and your clinician would be aware of that. Next slide, please. So I also want to go through then, what have we learned through our vaccine safety adverse reporting system? As I said, over 160 million doses have been given in our country, and many, many more million around the world. As of, and we'll talk about the Johnson & Johnson vaccine first, the thrombosis with thrombocytopenia syndrome with vaccination is incredibly rare. Over 12.6 million doses of the vaccine have been given in the United States. CDC and FDA identified 38 confirmed reports of people who got the vaccine and later developed TTS, but in an abundance of caution, recommended that women younger than 50 years of age, especially, should be aware of the very rare but increased risk of this adverse event. And so that the woman and their physician need to be aware of that before they get the vaccine and may consider the mRNA vaccine. Next slide, please. And then myocarditis and pericarditis following mRNA COVID-19 vaccine. Over 184 million people have received at least one dose, and 18 million people between the ages of 12 and 24 have received at least one dose. VAERS has received 971 reports of inflammation of the heart, which sounds scary, but myocarditis and pericarditis among people aged 30 and younger who received COVID-19 vaccine. That is an inflammation of the heart muscle and an inflammation of the lining outside the heart. In both cases, the body's immune system is causing inflammation in response to an infection or some trigger. And symptoms can be chest pain, shortness of breath, or palpitations. Most of these cases have been reported after the mRNA COVID-19 vaccine, particularly in male adolescents and young adults. And through follow-up, CDC and FDA have confirmed that 594 reports of myocarditis and pericarditis. Patients have responded well to medical treatment with rapid improvement of symptoms, and they can usually return to their normal daily activities and should speak with their doctor about when to return to exercise or sports. We continue to actively monitor these reports by reviewing data and medical records, and continue to recommend COVID-19 vaccine for everyone 12 years and older, given the significantly higher risk of COVID-19 illness and related severe complications for children versus this incredibly rare risk of an adverse effect. Next slide, please. So I think this is actually, if we look this week, 184 million doses of COVID vaccine. 55.5% of the population has gotten one dose. 48% are fully vaccinated. But as you can tell by the varying colors, and green is the least vaccinated, and the dark, dark, dark navy black is the most vaccinated parts of the country. We really have significant differences in how many people are vaccinated in different parts of our country, which is really important for us to know for where we live and the people we may be exposed to or be exposing, but also in trying to champion in your communities that people all be vaccinated. Next slide, please. And what does that look like? This is data from yesterday that I wanted to share with you. That means 184 million doses have been given, that we have 159 million people in our country that are fully vaccinated, which really is a historic and something we should all be very proud of as a country. 48% of people in our country are fully vaccinated, and that includes everybody from birth to death. If we go down and look at people over 18 years of age, 67.7% with one dose, 58.9% with fully vaccinated. And then for people over 65, 88.7% with one dose and 79% who have been fully vaccinated. So this is an historic effort by our country writ large and every single one of you. And I would say the most important thing I can say today is thank you for listening and learning about vaccination, because that's how we continue to protect our country. Next slide. I know everybody's hearing about variant viruses and vaccine effectiveness, and wanted to share with you preliminary data about what we're learning. Scientists are studying these variants to learn more about them and to quickly detect new variants. They want to understand whether they're spread more easily from person to person. Do they cause milder or more severe disease in people? Will they all be detected by our currently available viral test? And will they respond to medications currently being used to treat COVID-19? And could they potentially change the effectiveness of COVID-19 vaccines? So there are currently ongoing studies that are being done across the country to try and answer all of those questions. Next slide, please. And then again, in complete transparency, want to share with you what we know. No vaccine is perfect, and we know that no vaccine works 100% of the time. And if we think a vaccine works 90% of the time, it's extremely effective. But that still means 10% of the time, someone may not have an adequate immune response to the vaccine. It's why you've heard people talk about herd immunity or having as many people in the community be vaccinated. So what we've learned is we define a COVID-19 vaccine breakthrough as a COVID infection in a person who is fully vaccinated. So that's after their second dose, 2 weeks later, or after the first dose of Johnson & Johnson. With over 150 million people vaccinated, we do expect, as I would say with that math, thousands of breakthrough cases to occur. Evidence suggests that vaccinated people with breakthrough infections will have less severe illness than unvaccinated people who get COVID-19. Despite this, there will rarely be fully vaccinated people who still get COVID-19 and will have a very severe or fatal infection. And as you can see the numbers here, it is more likely that you'll have a breakthrough infection if you are older, and asymptomatic infections versus hospitalizations. And as you can see, 20% unfortunately resulted in death. Next slide, please. So we have created a passive surveillance system that aims to capture all breakthrough cases that occur throughout the country and to monitor for trends in vaccine breakthrough infections. So we're looking at each individual case, who they are, how old they are, where they live, what vaccine product they received, what type of variant or viral lineage they have, to be able to look at all that information together to help identify if there are trends that might support further investigation or any adjustments to the vaccine recommendations. Ultimately, we identify this through something called the National Notable Diseases Surveillance System. And so across the country, the CDC and state and local laboratories are performing that viral sequencing to look for variants and to look for changes in variants. Next slide, please. Next slide, please. I'm not sure if we're advancing. Are we still there? Next slide, please. There we go. Thank you. Thank you so much. So what else we're doing is we're starting a project to evaluate various viruses, and it will be sites around the country that we'll be using to really look for these things. So next slide. And lastly, where are we going looking ahead? We want to continue to surveil. We talked about the variant viruses so we can prepare and adapt to understand the questions people ask. Will we need boosters? Will we need to change how which spike protein we respond to? That work continues. We continue to study vaccine effectiveness studies to make sure we're studying multiple different populations, not just geographically, but types of chronic diseases, people who are immunocompromised, to understand how effective the vaccine is. We continue to expand groups of people who are eligible. And as you know, this summer we expanded to adolescents and fully anticipate that sometime in the fall, vaccine studies will be available about the safety of vaccinating children. We continue to do exactly what we're doing today, is to talk to people about vaccines and how vaccines are produced and how we then look at vaccines afterwards to demonstrate that they are safe and effective. And most importantly, making sure that every American, and as we've heard, anyone in the world, that we try and make sure that people have access to vaccine so that we can end the scourge of the pandemic and have equitable distribution of these life-saving therapies. Next slide, please. And the last, and we will share with you these slides, but here's more information for you. Where you can find a vaccine if you haven't been able to quickly use this website to identify where to get vaccinated. And then the next slide are the CDC web pages on underlying conditions if you want more information. And then we have additional resources for healthcare providers. Next slide. And I will stop there and turn it back over to you and see what questions people may have. Thank you so much.
Thank you so much, Dr. Remley. That was wonderful. And we do have several questions that have come in, and I'll apologize in advance if there's some repeat in the information that you might have already presented, because it was a brilliant presentation with so much information. So we really appreciate that. The first question that comes in is, can you please cover your thoughts on the booster shot? It seems that Pfizer and the CDC may not be in line with each other, and it might get confusing.
Sure. And the way I would explain that, and I'm not a vaccinologist, so I'll admit that up front, is Pfizer's preparing for what may be needed in the future. So, they're the vaccine manufacturer, so they're looking at, if we do need a booster, how do we make sure we're ready for it? What the CDC is saying is currently we don't have information that says that we need a booster right now. So I think sometimes the press wants to make us appear, that everything seems to always be at odds, but it's really different people in different roles making preparations for the time. So if you're Pfizer, you're thinking about, if I have to make a booster, what do I need to do and how will I do that? If I'm also making vaccine for the rest of the world and for our country to be vaccinated, we're thinking about what are the public health needs now. And we will look and continue to look at the science and the experience to say if and when a booster might be needed.
Great, great. Thanks, Dr. Remley. This might be something that you had presented earlier in the presentation, but I'm going to ask this one. Can you explain what is going on with immunocompromised people and their medications interfering with the effectiveness of the vaccine?
So that's a really important question, and one that I would always say to any individual that is immunocompromised to have a very thoughtful, careful conversation with their clinician who is providing them that therapy. Because if we say immunocompromised, it is a broad category. And some people may be mildly immunocompromised, some people may be severely. And so understanding what that means, having that conversation with your clinician to understand when in the cycle of your medication you may want to get vaccinated, and to understand also the potential that if that vaccine is less than effective, do I continue to need to mask and be able to live my life as fully as possible. We don't, because it saying immunocompromised can be anything from someone, who is has just had a transplant and is significantly immunocompromised to someone who has a chronic disease and is moderately. And the differences are enough that we really encourage people to talk with their clinicians. If they're unable to talk to their clinician, we do have a CDC hotline that their doctor can call and talk to experts at the CDC to discuss their specific cases.
Great. Great. Thanks, Dr. Remley. This question is rather interesting. Nothing that I'm not familiar with, but you may be. It starts as, we've heard reports of individuals from other countries engaging in vaccination tourism. They travel to the U.S. to get a free vaccine. I live in a state where that is rampant. Is it taken into account when tallying the vaccination rates?
So interesting, a very good question. It's interesting because I met somebody just recently who told me they were here for 2 months from another country, and I said, "Oh, why?" And they said, "Because we're here to get vaccinated." I think that is the wonder of our country, in that it was decided early on that vaccine needed to be equitable and available to everyone. So we wanted to make sure that states were not, putting up barriers for anyone. That being said, each state functions differently, and in terms of any kind of requirement to show your identity.
Mhm.
So there's not a federal requirement that you show, that your passport or that your permanent address or whether you're documented or undocumented. That is done on a statewide level. And I think that states report if they know people are from out of the country, it's reported that way. But if somebody does not declare that, you're not going to know that. And so I think the important thing to know there, as we look at our immunization rates, we should always say this is the lowest, not the high. This is a rate that could it have a little room. We also know that so there may be people in there who did come here to travel, but in the bigger perspective of 184 million doses, we're talking small numbers, right? But it's one of those things that does happen. And actually, I'm the fact that we as Americans are trying to make sure everyone can have access to vaccine is something we should all be really proud of.
Yeah, yeah, well said. Thank you. The next question, are there any current updates on vaccines becoming available for younger children under the age 12?
So I know I can tell you that Pfizer, Moderna, and Johnson are all doing those clinical trials. I do not know when that information will be available. They keep that information pretty closely, but what the process will be is, and we know those trials are actively going on right now. The process will be when they have enough cases to be able to bring them forward to say, here's how many people were immunized, here's how many people we protected. The numbers are big enough and they've looked long enough. They will bring that data to the FDA. The FDA will look at that data, and if the FDA decides the data is valid and shows that the vaccine is safe and effective in that age group, they will then make a recommendation and provide an EUA. And then after that process occurs, the CDC director asks the advisory committee on immunization practices, who are experts in medicine from across, from everything from pediatricians to OBGYNs to infectious disease doctors and ethicists, to come together. It's an independent body. They will review the data that the FDA and the companies brought to them. They review all of that data, and then they make an independent decision where they vote and discuss about whether they are going to make that recommendation to the CDC director to approve that vaccine for use in children. So that's the process that will occur. The first thing we will all hear is when one of those companies says, we're now going to the FDA with that data. I think everybody anticipates that hopefully that will occur sometime this fall, but I don't have any crystal ball to tell you when that's going to happen. But as you can say, I said at the very beginning, I'm eager because I want to make sure that my grandson gets protected as soon as he can be.
Yeah, which we got a lot of comments on what a great intro that was. So appreciate that. The next question is the CDC came out with updated guidelines for schools for the fall. My understanding is students who are vaccinated don't have to be masked, but others do. And I believe the 3-foot distancing rule still stands. Can you clarify on that? What are you hearing are the challenges schools and school districts are facing trying to implement these guidelines?
Yeah, well, I don't have the guidelines in front of me, and I apologize because I don't want to misstate what they just said. And so I'm going to ask Francesca's going to find out and get us the exact right guidance because that's not my area of expertise. I think the important things for people to know there is each state, these are guidelines from the CDC. So the CDC issues guidelines, the states accept them or don't. They're not a law or a regulation. So each state uses those guidelines and implements them as they see appropriate. They then make recommendations to their local school districts, and then those local school districts make decisions. As you can imagine, this is going to be easier in adolescents who we hope that the majority have been vaccinated. It'll be harder with small children, but we also know that in smaller children, we've worked very, very closely with the CDC has with school districts around the country, identifying what practices made the biggest difference. So mask wearing, hand washing, how to put kids down, the guidance that went out was much more in the classic effective, what worked well to prevent disease. And how do we do that? And a part of that also is kind of keeping children in cohorts so that you're not mingling, you're lessening how many kids are mingling every day. But and here, Francesca, you are the queen. So here's the guidance for, I hope everybody can you see that, Brett?
Yep, we can.
So here are the key takeaways. And thank you, Francesca. So this is looking at, so we said this, if you look at the second to last bullet, the prevention strategies are critical to protect people, students, teachers, and staff who are not fully vaccinated. So 3 feet away, you were right, a physical distance between children within classroom with indoor mask wearing by people who are not fully vaccinated. And I would say, and this is just Karen talking, what's the hard thing there? School districts have to decide, do children self-declare if they're vaccinated? How do we do this? Do we have everybody wear masks because we don't want to ask or have somebody feel awkward if they're not? And so these are recommendations, but across the country, as with everything else, there will be different interpretations based on what those local health districts and school districts decide to do.
Great. Thank you, Dr. Remley. Another question that comes in, many borders remain closed to international travel, which is substantially impacting many families and businesses. What needs to happen for borders to be opened again? And is there a specific data threshold?
Yeah, so if you look at the CDC website on international travel, just like we started off saying that, disease is moderate in our country, for Americans that are traveling out of the country, there is a requirement that, before you get on a plane, depending on what country you go to, that country will have requirements before you get on that plane to go to that country. The United States right now requires that you demonstrate that you've had a negative COVID test. It can be an antigen test or an antiviral test within 3 days, 72 hours of your returning to the United States. The United States does still have some countries that it is saying that people can't come in from. And I think I speak for the people that are in the global part of the CDC. They understand so much that burden that places on families. And so they are very carefully monitoring disease levels in all of those entities to understand in those countries when those borders can be opened. So it's a two-way street. There are some countries who don't want us coming from the United States, unless we can demonstrate we're fully vaccinated. There are countries that we're saying the disease level is so high that in order to come from that country into the United States, you have to demonstrate that you have a negative COVID test. And then there are some countries where the disease is so high that if you're not an American, you're not coming in right now. It is a very complex issue in terms of understanding various levels and wanting to make sure that we can abate the pandemic. And what I would tell, everyone I know, and I tell all of my family members around the country, the thing you can do for yourself, but also for your friends, and also for your friends who have family in other places, is get vaccinated. Encourage the people you know and love to get vaccinated, because the more vaccination we have, the less disease we have, the faster those borders open between our countries.
Yeah, well stated. Well stated. The next question that comes in along the same lines, with all the recent news about the spread of the Delta variant, should we go back to limiting social contact, meeting outside, or wearing masks, even with close friends and family members?
So that's a great question. And I am not going to speak officially, but what I would share with you, this is as a clinician, if you look at the map of the country, and you look at where we showed immunization rates, if you're in a community that has very low immunization rates, odds are much higher that you're going to be exposed to the variant or to somebody who has active COVID infection. If you have, we know that even though the vaccines are very effective, they're breakthrough infections. So you're putting yourself at higher risk in communities that have less vaccination than you. And so here's an example of that. So if I'm in Atlanta, Georgia, and I go to the grocery store tonight, the questions I need to ask myself is, okay, am I in the 94% of people who are fully vaccinated, or in the 6% who might have a breakthrough infection? Do I have any reasons to be significantly concerned? And am I going to be potentially close to people who might not be fully vaccinated? And that's how I personally make a decision about whether I'm going to wear a mask or not. And I have no qualms about, I think this is a personal choice, but it's balancing those risks versus benefit. And the risk to me of not wearing a mask in a situation that I don't know all that information versus the benefit of being able to wear a mask and feel more comfortable that I'm not going to get sick or get someone else I know or love sick. I'm still being conservative. But again, it's balancing those various pieces of data.
Yeah, great. Thank you. A couple more questions. You have mentioned multiple systems of collecting surveillance and safety data. How is this data combined, and who monitors it for accuracy?
Sure. It's an excellent question. So it's combined and monitored by the FDA, by the Department of Defense, by the CDC, and by those academic medical centers that you saw, and then by the NIH. So there are the federal government funds studies, but those studies are done independently, and they have independent, what we call institutional review boards. So if I'm going to do a study, for example, at one of those immunization centers, they will send the data to the CDC, but that actual academic medical center has to go before an institutional review board that identifies the research to make sure it's appropriate and it's ethical, and that the results will have an impact on people's lives. So there's multiple checks and balances there to make sure that there's no messing with the data, for lack of any other way to say it, to make sure that the data is very carefully, very accurately interpreted, and to make sure many institutions look at it to make sure that there weren't any perceived biases in how that data is interpreted before it's then released to the public. When it comes to the vaccine VAERS system, as you saw, the CDC is very transparent that as soon as there's any kind of a potential safety signal, they very quickly publicly talk about that to make sure that all of those different systems that are monitoring know that there's a potential there. So they are going to look more deeply and see what they see. So a very open and transparent process.
Great. Thank you. We have one last question that's come in, and it's is the recommendation for those who are immunocompromised, who have completed the vaccine, to get an antibody test to assess its effectiveness for themselves as an individual?
There are clinical trials being done right now to look at that. But it's one, again, something that I would talk to your individual clinician about, because again, the hard thing here is what is the diagnosis of being immunocompromised. So you want to be able to talk to your doctor and say, am I truly immunocompromised? What do I need to do to identify whether, I have adequate protection or not, and whether I need to continue to mask or socially isolate. So there's not a global recommendation for that, but here's information. Thank you again, Francesca. So for the general public, you can read about precautions, but then you can also look here, which I think is important for clinicians, and this gets updated every week. There's clinical care, but also what's the underlying evidence? And that underlying evidence, as we have more and more data coming forward, gets updated every week to answer those important questions.
Great. Thank you so much, Dr. Remley. We really appreciate your time and expertise in presenting to the community. I'd also be remiss if I didn't thank Francesca and Shay as well too. So thanks to
They
them.
are they are the wind beneath my wings. It always takes a village, and we are. I hope that everybody heard today. I think if I could say anything, is the people here at the CDC work incredibly hard to make sure we gather as much objective information as we can, and then we share it as openly and transparently with everyone as fast as we can, so that people can make good decisions for their health and well-being and their families and communities.
Yeah, well said. Well said. And thank you so much. We appreciate it. And everyone, please note that this webinar was recorded and will be available on Friday, July 16th at hemophilia.org under the events tab with all of our other archives Wednesday webinars. Thank you again, Dr. Remley and Francesca and Shay as well too for taking the time to do this and getting this set up. We truly appreciate it. And the community is grateful to you for your time. Thank you so much.
Thank you.
Great. Have a wonderful week, everyone.